Baron has a remarkable new book, which is called Waking Up Safer. It just got amazing reviews in one of our major journals. So I would encourage everyone here to read it. And we're actually going to get some copies for our PAT clinic, because some patients, it's really an interesting idea for them to look at it as well. So without further ado, it's once again a privilege and a pleasure to introduce Dr. Metz, who's going to talk today about waking up safer, an anesthesiologist's perspective, and give us a little history of what's happening in our specialty. So
good morning, everybody. It's a pleasure to be back here at Yale. And as Dr. Hines said, I was a residency director, so over the last 25 years or so, quarter of a century, sounds terrible, I always gave the introductory lecture series to the incoming residents. And the key part of that was that in about half an hour, I wanted to bring residents up to date with the history of anesthesia to the present time. And so, as you do, you slowly develop this lecture over 25 years. I had lots of time to develop the lecture. And at one stage I thought, well, maybe this is quite interesting. Why don't I try and put this together in a book? So we're more or less coming full circle now, where I'm presenting a book or something that's in a book based on what I developed over the last 25 years or so. So I've entitled this talk, Waking Up Safer, A Brief History of Anesthesia, a balance between safety and death. And here's why. In what some would consider the first general anesthetic ever, Horace Wells self-administered nitrous oxide to unconsciousness for a tooth extraction. He decided he would push it to the limits, so he drew in the nitrous oxide, turned blue, became apneic and unconscious. And Dr. John Riggs, who was the surgeon, the dentist at the time, said, "We knew not whether death or success confronted us." Now, before the advent of anesthesia, this is what an operation conducted by Dr. Robert Liston, one of the foremost surgeons in London, looked like. There was a single operating room, always at the top of the hospital, for two good reasons. One, they had a skylight so that ambient light could allow the surgeon to actually see the surgery. And two, as the surgery started, a bell would be rung. They'd close the door to minimize the screams emanating to the rest of the hospital. The usual procedures was that a somewhat stupefied patient, having inebriated themselves, would be led into the operating room and then held down by 6 stout men, as you can see right here, one around the chest, 3 bringing down the arms and legs. And the bad leg would be held and steadied while the surgeon got ready his sharp instruments. Robert Liston, who was famous for saying, "Time me, gentlemen, time me." And then people would stand up and rise up, whip up their stopwatches, and he would slash through the amputation. In under 25 seconds, he was that fast. On one such occasion, before the advent of anesthesia allowed people to be more careful in their surgical approach, he cut straight through the patient's leg, the assistant's hand, both who died from the surgery. Somebody standing in the audience stood up, received a heart attack, fell over and died, and the only surgery where there was a 300% mortality. So as I've just said, death from surgery was very high, and around the 1800s, of every 2 patients, 1 would die after surgery, either from the shock of it all or from sepsis. Now I'm going to tell you this story by stopping off at a number of different points. We'll start with the story of general anesthesia, gases and vapors. Then we'll talk about how anesthesia develops the approach to balanced anesthesia, using intravenous anesthesia as well as muscle relaxants. We will then touch on a few points around how we enhance anesthesia safety through equipment. And finally, we'll pull it all together in how we've managed to improve patient care and the lines of the parachute that we have drawn together to enhance that safety, and ensuring that there's been a 90-fold improvement in the past 60 years. In order to do so, we're going to jump from the New World to the Old World and back again. But let's start in the Old World with Joseph Priestley. Now, Joseph Priestley was a preacher, he was a teacher, he was a chemist and a laboratory scientist. He started in somewhat straitened circumstances, but he married well, so he did extremely well after that. Only one day in Leeds, he synthesized nitrous oxide back in 1792 by focusing sunlight on iron filings in the presence of water and nitric acid. Now, the problem for him was that this nitrous oxide killed his mice, so he called it poisonous, wrote about it in 3 books on air, but left it aside for the moment. The next person we need to know about is Henry Hill Hickman. Henry Hill Hickman provided a singular solution to one of the problems of anesthesia, and that is he suggested that it could be a gas. He practiced on his dogs, as you can see here, and he practiced asphyxiation or suspended animation. Basically, he'd put the dog in the glass cistern. The dog would pant away, become hypoxic, build up carbon dioxide, would then, as a result of that, become unconscious. He'd whip the dog out, cut off its ear, and so showed painless surgery, the dog recovering after the event. He presented this to the Royal Society of Medicine, but they didn't want to hear about it, and in despondency, he committed suicide, and that was the early end of Henry Hill Hickman. We now move to Bristol, where we move to Dr. Beddoes. Now, Dr. Beddoes started something known as the Pneumatic Institute. It was geared to develop therapies by using gases, many of the gases that had been described by Priestley 50 years previously in his books. But he needed somebody who would look at what could be done with nitrous oxide. So fortunately, he got a letter from one of his chemist colleagues, and who suggested that he try Humphrey Davy. Now, Humphrey Davy was young, rakish, and fearless, and he set him to the task of finding out what we could do with nitrous oxide. Now, Humphrey had also read Priestley's books, so Humphrey was very, very concerned about nitrous oxide, so he didn't want to use the laboratory's pigeons to practice on, so rather, in the tried and true fashion of medicine, he practiced on himself with the nitrous oxide. He was asked to come and present his findings at an arrangement with Dr. Beddoes, so he pulled together the nitrous oxide in a silk bag, sat himself down on a stool, and inhaled in front of Dr. Beddoes. Became stuporous. Now, I think all of you know that nitrous oxide has no usable oxygen in it. If it is to work, you need at least 100% filling your lungs. So you're going to be apneic, you're going to be unconscious, hopefully, and you're going to be blue, right? Because you're asphyxiated. And a great deal of nitrous oxide anesthesia was literally asphyxiation. So lay over back, everybody was terrified because here was this unconscious person, no pulse oximeters, of course, to show anything. And then he lay there, and then he got up and he started giggling. And that was the new therapy, a therapeutic use of nitrous oxide. So laughing gas parties became all the rage in and around England and, of course, eventually in America. We now move to Gardner Colton at Columbia Presbyterian, or the New York College of Physicians and Surgeons. Gardner was a chemist and an impecunious medical student. In fact, he didn't have enough money to continue on in medical school. So he needed to supplement his meager stipends. And so what he would do, he would go to the ladies' tea parties in Manhattan and do some chemical demonstrations. Having heard of nitrous oxide, he decided to share the nitrous oxide with the ladies at the tea party. His fellow medical students said, "This sounds like great fun, why don't we try it?" So his fellow medical students tried it, and they loved the nitrous oxide laughing gas parties. And they said to him, "Well, why don't you go commercial? Why don't you see if you can make some money out of this demonstration of nitrous oxide and usage?" So he said, "Okay, let me do this." And he went to the owner of the Broadway Tabernacle and suggested, could he hire the tabernacle so that he could do his presentation of nitrous oxide and have people come and use it? And of course he did. He advertised widely. He advertised that in 1844 he would have 74 gallons of the gas. 34 young men volunteered to take the gas that day, and 12 stout men would be there to hold on to the volunteers as they cavorted around the stage so that they would not injure themselves. On the day of the event, despite the fact that prices were steep at 25 cents, the place was completely packed. Gardner raced onto the stage much like this, first did his nitrous oxide demonstration and talk, and then people came up on the stage one by one and had the nitrous oxide. It was a laughing success. He earned $535 and it was back in the medical school business, and he decided to go commercial, and he started traveling around the states, and ended up in a grand exhibition in Hartford, Connecticut, to do such a presentation. Now we meet Horace Wells. Now Horace Wells started off all right. He came from a good family, became a dentist, but ended up quite peculiar. But Horace had always worried about the pain of teeth pulling. And so when he read in the Hartford Courant about this grand exhibition that was going to be presented using nitrous oxide, he thought, let me go and sit down on a stool and watch this event in the town hall. On the fateful event, Gardner Colton reprised his usual presentation and demonstration, and Horace Wells went up onto the stage, tried the nitrous oxide, made a complete fool of himself, and went back and sat down next to his colleague, Sam Cooley, on a stool in front of the auditorium. And then Sam Cooley, his colleague, went up onto the stage, got up onto the stage, fell around the stage after receiving the nitrous oxide, and knocked his knee on one of the stools. This is Sam Cooley went down, sat back next to Horace, and Horace said to him, "Did you feel any pain?" And Sam Cooley said, "No." That got Horace Wells thinking. So after the show, he went up to Gardner Colton and said, "Has anybody used nitrous oxide for teeth pulling?" And Gardner said, "No, but let's try it. I'll make you some, and we'll try it." And the next fateful day, these things always seem to happen in the middle of the night, but this is exactly what happened. They congregated together at Horace Wells's place. They'd built the nitrous oxide. It's not exactly how he did. He did it himself. So Horace Wells actually inhaled it himself, became completely stuporous and out, and Dr. John Riggs commented, "We knew not whether death or success confronted us." His mouth fell open, so Riggs immediately pulled out the offending tooth that was part of the plan, and Wells just lay there. And then they threw some water over his face, which was the usual approach. He spluttered up, he woke up, and he said, "It is the greatest discovery ever made. I didn't feel as much as a prick of a pin." And he ran all over Hartford, Connecticut, basically saying, I have it, the answer to tooth pulling. Now then, having heard of this, William Morton, who will appear again later, a dental associate from Boston, secures an invitation for Horace to demonstrate nitrous oxide for surgery at the Harvard Medical School. As you can see very nicely here, when eventually the ether dome. The venerable surgeon there is Dr. John C. Warren, who's had a long career in surgery and has always wanted to find a solution to the horrific pain that he caused on his patients. So on a fateful day of January 1845, Horace Wells presents himself to demonstrate a lack of pain from teeth pulling with nitrous oxide. He gives his usual lecture about laughing gas and tooth pulling, and then administers a bag of nitrous oxide. But he's a little worried because he didn't have the same pure nitrous oxide he usually has that Sam Cooley made. Sam Cooley wasn't there to help him, and he withdrew the bag too quickly. So with the obvious results that as he starts pulling the tooth, patient cries out, groans, and as a result of that, he gets booed out of the auditorium, the audience shouting, "Humbug, humbug, humbug." And in despondency, Horace Wells closes his practice the next day and disappears off to New York City and actually starts making furniture and painting. Ultimately, of course, Horace Wells, also in the despondent state, starts taking cocaine and chloroform, and bespatters a number of prostitutes in New York City, gets incarcerated, and commits suicide by femoral laceration in the prison. So another untimely end for many of the protagonists in this long story. Now we get to one of the most important protagonists in the story, and that is William Morton. Now, William Morton was always in a hurry, and usually a hurry to make money. Today we would call William Morton a psychopathic narcissist. But then he was just a swindler, wanted in 3 states for embezzlement before anything happened as far as anesthesia was concerned. He was really looking for a way to make money out of anything. Nobody's 100% sure how Morton got the idea of using ether. What's likely is that Dr. Charles Long, who was his mentor as a medical student at Harvard, he never completed his medical studies at Harvard Medical School, but in order to marry his wife, his father-in-law said, "You will go to medical school." And so he went to Harvard Medical School. But anyway, Charles Long probably told William Morton, here is what you can use, not chloric ether, but sulfuric ether. Why don't you try this? And the most likely thing is what happened is that Morton probably just inhaled it once himself and then wanted to find an opportunity to stage a public demonstration that he could advertise the use of ether. So he went around the wharves of Boston looking for somebody who might be willing to do it. Nobody was willing. Fortunately for him, 9 o'clock that night, somebody by the name of Eben Frost arrives. Eben had a painting tooth, and he said, "Could you please help me?" And he said, "Oh yes, we can help you." And that night, that very night, as you can see here, Morton puts a whole lot of ether on a handkerchief, clasps it across Eben Frost's mouth. Eben Frost passes out. Morton later says he looked more like a corpse than anything I've ever seen before, but nevertheless takes the chance, and Hayden, his assistant, whips out his first tooth, or the offending tooth. Eben wakes up, tooth's on the floor. He says, "This is a great wonder." And on his post-operative visit the next day, Morton finds Eben to be completely fine without any sequelae. Now, the very next day, an article is published in the Boston Journal about this event. And that's because Morton had the foresight to bring a journalist into the proceedings that very night. Also, he practices on around 37 patients observed by the very important Dr. Henry Bigelow, and immediately takes out a patent application for lithium, which was completely unheard of at the time. Yes, you would do it for dental work, but you would not do it for science. And what he tried to do was, of course, he took a sulfuric ether, added oil of orange essence, and tried to hide the obvious signature smell that you and I all know. And then he gets invited by, again, John C. Warren, on October the 15th to demonstrate painless surgery at the Massachusetts General Hospital. But he goes into a panic because he knows he's just got sulfuric ether, which has been around for 500 years, and he needs an invention because then he can sell something. And so he turns to Augustus Gold, and Augustus Gold is a glass maker and conchologist, and so he fashions for him very rapidly this first device, which is actually the device that was used for the first anesthetic. This was the second anesthetic subsequently, and you see it's already got valves and other appurtenances attached to it. So the very next day, of course, he has to be ready for this event. October 16, the fateful day, 1846, arrives, and the who's who have been gathered in the auditorium. It's literally stamped full of pharmacists, doctors, scientists. There's even a Daguerre-type photographer who's also standing in the auditorium. And the patient gets wheeled in. The patient's somebody by the name of Gilbert Abbott, who's had a jaw tumor from birth. He's tubercular, weak, and poorly dressed, and gets strapped onto the operating room chair just in case. The start time is 10 a.m., and not surprisingly, there's no Morton. And so Don Warren paces around, And Surgeon Hayward says, well, let's start. I mean, we don't care about no anesthetist, let's start. And Warren says, no. I've heard about somebody who will demonstrate painless surgery. I've been waiting for years. I'd like to see if this will work. Meanwhile, Morton has just made the final fixes to his new apparatus. Gold had to fix something for him. And that's why he's late. He knows he's late. He's running along the outside here. This is the new Harvard Medical School. He's running over here, and he is making his way, as we speak, right up these stairs. So he's got to run 3 stairs to the top of the auditorium. And he's standing outside. He's waiting for a lull in the proceedings, and he's waiting to go in to make his entrance. He composes himself. He walks into the room. He sees the whole auditorium, the wall they used to call it, sees the whole auditorium. Everybody's focusing on, now, this looks very nice, but this would be sawdust, of course. You know, usually it would be sawdust so that all the blood could seep into the sawdust. He crunches into the room, and right at the center of the room, of course, is the patient. And even Frost is also in the background. So he walks over to the patient and says to the patient, are you scared? And Abbott says, no, I'll do exactly what you want me to do. So he administers the ether, and he goes literally completely numb. He coughs a bit, and then he goes numb. And Morton turns to Warren and says, your patient is ready, sir. And Warren slices, and everybody is totally silent because the patient doesn't move. Cuts through the tumor, and just at the end, the patient starts waking up slightly, but he's just suturing closed the wound. And Warren turns around to the auditorium and says, gentlemen, this is no humbug. And of course, pandemonium breaks out. Everybody congratulates Morton. And the news of this literally spread across the world in the first article by Jacob Bigelow, who was, some would say, was the fourth inventor or discoverer of anesthesia, because he was the promoter of anesthesia around the world. Right, now we continue the story in England, in the old world, and we turn to James Young Simpson. So James Simpson started his career as an obstetric surgeon and anaesthetist eventually under a cloud because he bought his way in. But he was an excellent lecturer, and so he made up for it very soon. Now, he was starting to use ether, as described by Morton, but he didn't like it much. One, it smelled, made people sick. It was flammable, of course, but worst of all, it was made in the USA. And as a result, he wanted to find something else. And now he was a rather stout man, and he loved to have dinner parties. And the usual practice would be that at the end of the dinner party, much like a dessert menu that I was offered last night, what they offered then was to try a number of chemical compounds that were known for their volatility to see whether they could demonstrate the next anesthetic or find the next anesthetic. And on one night, chloroform was on the menu. And this is what it looked like after that. So, of course, the next anesthetic, chloroform, was found serendipitously and then made its way literally around the world. The biggest problem with chloroform was, of course, that it killed. It killed Hannah Greener first in a well-described study. But it was so dangerous that first investigation was unlocked not soon after by the Royal Medical and Surgical Chloroform Committee. And they cottoned on early that the problem with chloroform was, of course, that they didn't know this, but we know this now, that the patient would go into ventricular fibrillation. And so they suggested that balanced anesthesia be their approach. As early as this, that you basically mix a mixture of anesthetics, alcohol, ether, and chloroform for the induction in order to have less toxicity from a single agent. And so we have balanced anesthesia, which we'll get to in just a minute, but I just wanted to point out that in 1909, more people died from chloroform than were murdered in England. It was that much of a public crisis. And people don't often appreciate that. As I told you earlier on, the idea behind giving this lecture was to bring you up to date, at least where we are now, and of course you can see how we have changed. But the most important inflection point was, of course, halothane, because all of the others were serendipitously found and had been designed for use for other things. And then halothane was the first synthesized, synthetic, designed anesthetic, which ultimately enhanced our potential to provide safe anesthesia. We return now to balanced anesthesia, and more specifically intravenous agents. Now, Dr. John Lundy taped a little butterfly wing to the philtrum of his patient. He was terrified that the patient would stop breathing. At this time in 1934, if you stopped breathing after administration of an anesthetic, electrocution was tried, vain attempts with a bellows or a little squeezing of the chest, but if you stopped breathing, you were dead. And so when he started introducing intravenous thiopentone, he was most concerned that the patient continued breathing throughout the episode. And so he taped this little approach to let him see that the patient was still breathing. Then he would take the sulfurous thiopentone in a 20 cc syringe. He would inject it into the vein, aspirate blood into it to make sure he was in the right place, and then slowly ask the patient to count to 10. That's where it came from. And slowly give the thiopentone. If the patient wasn't asleep, he'd caution that you give a little more, another 1 or 2 cc's, until the patient stopped counting. If the patient stopped breathing, he said you must stimulate them a little bit to get them breathing, and he thought that if they went blue, that was not a good idea. So he then, of course, introduced intravenous anesthesia. It wasn't the first, but it was the one that caught on the most, and as you can see now, we, of course, have many new agents and some that will be developed in the future. We move now to curare. Ecuadorian jungle Indians knew well that if they wanted to interrupt the flight of their prey, they should shoot them with a dart which was tipped with an extract from lianas. This extract from liana would paralyze the bird, and the bird would, of course, be interrupted in flight. Now, this extract from these poison darts found its way to Claude Bernard's laboratory in France, where he investigated the effects of what would eventually become curare, finding in his frogs that although they were completely skeletally paralyzed, their heart continued to beat in the body. And from where this was developed then, curare. Now, back in 1942, Harold Griffiths, who was a merry, pudgy first president of the WFSA, but also of his own department at McGill, was always looking for a way that we could relax the abdomen when difficult surgery was being performed. And he'd seen a video of the use of the new drug called ecositron being used to minimize skeletal injury from electroconvulsive therapy. And so he thought, well, if I can get my hands on some of this, maybe we can try this in the operating room. And so on one day, when he had a particularly difficult appendectomy, a 250-pound plumber, the surgeons were struggling to open the abdomen, he said to Enid Johnson, his resident, give 5 cc's of this. So he gave 5 cc's of that, and immediately the abdomen was like dough, and he said, and as a result of that, we then started using muscle relaxation, of course. What happened first was that people would just continue breathing because they just give a little bit of muscle relaxation. But as we have developed the techniques, of course, next we have all these muscle relaxants, and now we've gone to muscle paralytic agents. And as a result of that, of course, clearly we needed more and advanced devices to manage ventilation of our patients. And so that introduces the next aspect of what I wanted to present in this story. Now, John Snow is one of the major protagonists in anesthesia in England. In fact, he is credited with writing the first anesthesia textbook on ether and chloroform. And he had also used the handkerchief method, that is, the handkerchief method of giving ether. And he was using it to provide equine anesthesia. He credited the handkerchief method with killing his horse. And so he said, we need something more sophisticated. We need a mask. And so he generated this mask in 1847. So that was the first real mask anesthesia. So Frederick Hewitt, eyesight was failing. So he decided to go into anesthesia because anesthesia doesn't seem quite as taxing as surgery. He was well known for being particularly good in calm in difficult situations, particularly airway situations. And this was probably because of this device that he developed, which was the first airway. And then the next step in all of this was the development by Arthur Goodell, who, despite the fact that he'd lost 3 of his fingers as a machinist before he ever went into medicine and ultimately became the chair at USC, created this Goodell airway, which of course focused the air more exactly onto the glottis rather than the straight one that we had before. Probably the most important inflection point in safety was the development of the LMA by Archie Brain. Now, Archie Brain was born in Japan. His father was a knighted diplomat, and he never really wanted to go into medicine. He actually went into linguistics at Oxford, but was so interested in the science of discovery that he decided to go into medicine. Archie also never wanted to go into anesthesia. He actually wanted to get a surgical job, but as in those days, he arrived at the hospital where he'd been signed up, but the surgical job was gone. So they said, "Why don't you try anesthesia?" And he said, "Well, okay." 6 weeks later, he said, "This is the greatest thing that I've ever done." And of course, he became an anesthesiologist. In the 80s, he was assigned to become a professor at the University College London, and his job was to invent things. And he wanted to do something that would really make a difference. And he got rather tired of mask ventilation, or just hanging on a mask, as we all did in those days, as we administered anesthesia. At the time, Archie was doing a lot of dental anesthesia here with something known as a Goldman nose cone. Of course, the surgeon has access to the mouth as a result of the fact that you're just over the nose. And with his artistic mind, he looked at the nares, as you can see here, and he looked at the glottis, and he said that the triangular shape is obviously quite consistent. Could I not take this Goldman nose cone and put it over the larynx? And so he decided to try it. So he married a Portex tube and a Goldman nose cone, put it together on his table at home, and tried it on himself. And he spluttered a bit, and he said it worked. I could breathe through it. And of course, the rest is history. So we got the LMA as a result of that. And he also developed the intubating LMA, which, as many of you know, has created an enormous amount of safety for us all. And he says, "Isn't that the best thing?" when I hear another report of something being safe. He's now just doing Japanese art back in Japan. He doesn't do anything around academia anymore, but that's how he spends his time. And I was very fortunate to see him at the World Congress. Now, the next important step actually came from Dr. Harvey Cushing and Dr. Ernest Codman, who had competitively had a competition going who could give the safest anesthetic while they were housemen, interns. And they decided that whoever gave the safest anesthetic, least deaths and minimal nausea and vomiting, would pay the others dinner on a celebrated occasion. And probably as a result of this, they decided, well, we have to have a record of this safe anesthetic. And so that's how the first anesthesia records were inaugurated. Now, crucially, the record, of course, would ultimately allow us to dictate the outcomes, because only if you saw what happened in the operating room could you predict what the effects of anesthetics are on post-operative outcomes. Now, there has been a great deal in the development of monitoring. Before this time, people would generally just monitor the respiratory rate, sometimes the pupil size. And here is a staged photograph by Joseph Clover, staged because he wanted to demonstrate the fact that he is performing cardiovascular monitoring with his finger on the pulse. That is actually his father sitting there. And so it's not at all an anesthetic, but he's just demonstrating this as a demonstration of monitoring. Of course, over the years, we've had massive advances in monitoring at all the levels that you can see here. And I just want to point out again that the other big inflection point, no doubt, is the development of the pulse oximeter in 1983. What about anesthesia machines? Well, of course, you saw the first one. And, of course, anesthesia was brought to the patient in their homes. But when we brought the patient to the hospitals, then we needed a much larger piece of apparatus to carry the cylinders that were now becoming part of the anesthesia equipment. And so we have William Boyle's machine, or the Boyle's machine that we all know and love. One thing that we have all inherited from Boyle was that he was left-handed. And so the rotameters are always on the left. So thank William Gaskin Boyle for that event. We're now going to measuring outcomes of care. And more specifically, we are going to rest with Amory Codman. Now, Amory Codman was a surgeon, a Harvard surgeon, and he started the concept of the end result card, which was a documenting of the outcomes of each and every surgery performed. There was a great deal of resistance from the Harvard surgeons about this, and he was thrown out of Harvard Medical School as a result. One of the reasons being that surgeons worked on their reputation for speed, but not their reputation for outcome, as I demonstrated earlier. And so when somebody was actually going to measure outcomes, that was not well-founded with many of the chief surgeons. So he was booted out and he went into private practice. I said earlier that the death rate was very high, but the first important study was produced by Dr. Henry Beecher, who is, of course, the first professor at Harvard. He studied over 600,000 patients in 10 hospitals and looked at the mortality as it was at that time, and gives the facts there. Now, at that time, he called this a public health problem. So you can see that this has been an issue for many years, the death rate from anesthesia administration. Over the years, over the last 60 years, we've had a 90-fold improvement in this death rate, as you can see from this slide, and this is for many reasons. And I want to pull together some of those reasons in the lines of the parachute to safety. Firstly, we need to separate from the surgeons. Now, in around the 1910s, there was a call that there need to be individual anesthetists and that every hospital should have one, because people were giving so few anesthetics that they needed to have a concentration of people who actually knew what they were doing. And so our separation from the surgeons was, of course, crucial to the development of anesthesia safety. This brought with this enhanced training. You can't hear me? Oh, right. This brought enhanced training and the development of the specialty of anesthetics, improved anesthetic drugs and adjuvants that I described, better monitoring and documentation of care, and advanced equipment design. But the most important next steps are the developing science of medical care delivery. And I want to close with the telling of 3 stories around this and how the science of medical care delivery is enhancing our safety. And I want to do that by telling the story about Henrik Kellett. Now, Dr. Henrik Kellett, a Danish surgeon, is probably one of the best-known surgeons among all anesthesiologists. Many years ago, he completed his PhD looking at the pharmacology and physiology of the stress response. And he asked a singular question when he did rounds in his hospital. He said, why is this patient still in the hospital today? Is it because of nausea and vomiting? Is it because of pain? Is it because their catheter is still in? And he so exploded surgical dogmas one by one, asking for multimodal pain therapy, asking for approaches to fluid therapy, of discharging the urinary catheter, etc. And from that, of course, we now have standardized ERS protocols, which has certainly enhanced our safety and our outcomes. In 1934, Boeing was going for broke. The Army Air Corps had put out a tender for a new bomber. The bomber needed to have a range of at least 1,000 miles, needed to have more than 2 engines, needed to be able to fly at least 200 miles per hour, and be able to carry a massive payload. At the time, of course, there was great secrecy in aircraft design, and so Boeing decided to put in a prototype, the B-17 bomber, which would eventually be called the Flying Fortress because of all the fantastic turrets it had on it. This plane was so sophisticated that it had not 2, it had not 3, it had 4 engines, all of which needed to be individually adjusted to be optimal. It had retracting land gear, and it also had flaps to allow it to fly more stably in difficult weather. The competition was to happen at the Dayton, Ohio fields in 1935, and information that had leaked out suggested that this plane would cannily beat the competition, who was McDonnell Douglas. And as a result, Captain P. Hill strapped himself on the fateful day into his cockpit and roared down the runway with confidence. The plane took straight up into the air, a little too straight up in the air, stalled, crashed back on the runway, and burst into flames. 2 of the 5 people died, including Captain Hill. One reporter pointed out that this was just too much airplane to fly. The problem had been that because of the complexity of all the equipment in this new bomber, Captain Hill had forgotten to disengage the rudder, and as a result, the plane crashed. Boeing nearly went broke as a result of this because, of course, the tender went to McDonnell Douglas, and they decided to mothball this plane. But some test pilots said, no, this plane can fly. And they created an index card on which they created their first aviation checklist. Do this, do this, do this. They then tested this bomber again using a checklist, and 13,000 of the Leviathans were eventually created, flying 1.8 million safe miles, and probably turning the tide against the Luftwaffe in the Second World War. Now, there was a surgical crisis in 2005, and an English-sounding person from the World Health Organization in Geneva gave Dr. Atul Gawande a call one day and said, you are a surgical safety expert. Can you help us with this surgical crisis around the world? What had happened is that there are over 230 million surgeries around the world. But as a result of the fact that there is not the necessary level of sophistication in anesthesia and surgical services, of these 230 million cases around the world, around 7 million are left injured and about 1 million are killed. And so the World Health Organization saw this as a crisis and decided to call Atul to see what he could do about this to help create surgical safety around the world. So what do you do when you don't know what to do? You hold a meeting. So that's what Dr. Gawande did. He held a meeting at the World Health Assembly, or at the World Health Organization in Geneva, and he pulled together all kinds of surgical and anesthesia experts, including Alan Murray from Auckland. And they fielded a number of approaches to try and create an enhanced surgical safety. They thought about an incentive program for surgeons. That wasn't going to work. They thought about having a whole manual of things that you needed to do to provide safer surgery. That wasn't going to work. But they also heard about some people who started experimenting with checklists. And so they started thinking of this a little bit more, and eventually, using aviation principles, they created, of course, the World Surgical Safety Checklist. And, of course, they needed to study this because, of course, you needed a proof of concept. So what they did is they studied it in 8 institutions around the world in low and high middle income countries, including New Zealand as an example. And, of course, the outcomes were stellar. There was a 47% decrease in mortality, 37% decrease in complication rates. And from that, of course, we now have developed the surgical safety checklist, which is being used, or at least promoted, around the world. But was it just the surgical safety checklist that did this? No, it was not. It was the communication that has become so much better between us in a complex environment. And this is part of the system science that we have to rely on to enhance our safety management in the operating rooms these days. Now, I'll close with this last story. Elaine Bromley worked in the beautician business and needed a FES operation. So she was dropped off by her husband, a pilot, at the local hospital just outside London. And the anaesthetist, whose name is Dr. Alderman in my book, but that's not his real name. Dr. Alderman decided to give just a general anesthetic with an LMA, started a remifentanil infusion, then likely pre-oxygenate the patient, and as she went off to sleep with propofol, he couldn't open her mouth to put it in the LMA. The saturation started dropping. He tried a smaller LMA, still couldn't open the mouth. Saturation went lower down. Then she became completely rigid. He put a mask on her, couldn't get any air into the patient at all, into Elaine. Saturation went further down. A second anesthesiologist came in, Dr. Brand. He tried, they said, well, let's get some sucks, so they gave sucks. They tried a laryngoscopy, they couldn't see the larynx. Saturation continued going down. The ENT surgeon came into the room to try and help. A tracheostomy tray was brought into the room and announced. The ENT surgeon tried to intubate. Saturation stayed at 40%. After 25 minutes, saturation was still 25%, and she was starting to twitch from the effects of anoxia of the brain. Martin Bromley, the pilot, the husband, gets called at home. He said, there's been a problem with Elaine, please come in. He comes into the hospital and he meets Dr. Alderman, who basically just hugs him and says nothing. And he says, what went wrong? What went wrong? Well, there was a problem with the airway. Did you try a tracheostomy? No, we thought we'd just let her recover. She was now being transferred into an ICU where she was basically brain dead, and she died 7 days later. Now, Martin, being a safety expert and a pilot, said, well, is there going to be an investigation, like an accident investigation, that we would normally do in the airline industry? And they said, no, we only do one if we get sued. But the head of the unit, the ICU unit, decided that there must be something wrong here. So what he did, he asked for a report. And Michael Harmer was then the president of the AAGBI, and he provided the Harmer report on what actually happened in this room. Harmer, then as soon as Martin Bromley had read this report, he said, right, we're going to publish this. And from this report was created just a routine operation teaching video that could be used by anybody to try and forestall or avoid the terrible situation that Elaine found herself in. And also, Martin started something called the Clinical Human Factors Group around England and Britain to start looking at human factors design to try and improve the situation. Because, of course, what was happening was that while Elaine was dying in front of these three competent individuals, two anesthesiologists and one surgeon, they were so focused on just one thing. They were focused on managing the airway from above rather than going from below, because they didn't have a system to look at how they could do this more safely. Now, using this teaching video was Dr. Nicholas Crimes in Australia. And he thought of how can we use this, how can we put this all together in a human factors design approach to manage the airway and this crisis more difficultly. And one day he got up having these ideas percolating in his mind, and he wrote down the vortex approach. Now, I'm not going to teach you the vortex approach here, but the idea is that these kind of approaches using human factors design allows us to manage the patient safer. And as you know, there are only really 3 ways that we can manage the airway from above, and if things go critically long, there's only one way we can manage it from below, so surgically. And so this displays in a human-friendly way, in a crisis situation way, so that we can manage the difficult airway better. And by the way, when there was a vote held at the Battle of Seattle about airway design and what the different airway approaches would be, Martin said to me that when the people in the auditorium voted for which was the best approach, the vortex, the Canadian, or the American Society airway guidelines, the vortex approach got 90% of the votes. So clearly, this is a major advancement in enhanced safety. So I hope that I've given you a little background to the balance between safety and death, and more specifically, I've covered a balanced anesthesia, how we have enhanced safety, and how we have literally improved mortality 90-fold over the past 60 years. And I would like to leave you with this. You are most alive when you are scared to death. I thank you for your attention.